arrangements of the former Speaker of Parliament. So continue engaging. Later on we shall be sharing your reactions. My name is Priscilla Regina Naloga and welcome to Take Note. Today's woman suffers and grapples with so many issues, but one of them is one that is known as maternal mortality health, and that is something that challenges us as women. I'm not yet a mother, but I'm a nephew. I mean an aunt. I have nephews, so sooner or later I'm going to have to become a mother and experience these things for myself. But when you look at the mortality rate for 2020 in terms of maternal health, it was 23.8 deaths per 100,000 births, and that was in comparison to the one of 2022 that had an even lower rate, which shows that there's some sort of improvement. So the public health sector is actually doing everything tooth and nail to ensure that they continuously bring this maternal mortality rate down and down. So we are taking note of the maternal health and nutrition in Uganda. Here to have these conversations with me, leaders, medical workers from Kawempe National Referral Hospital. On my left, I do have Dr. Tomsange Simon, who's joining us as a doctor from Kawempe National Referral Hospital. Good morning to you, Dr. Simon.
Yes, morning to you, Priscilla.
How are you?
Good, how are you?
Very good. I will ask from a personal perspective, what is your view of the maternal health in Uganda as a doctor, but also as a man? As a man.
Yeah, maternal health in Uganda is a job ongoing. That's what I would love to say. We're not where we started from. We're not where we want to be. Like, there's quite a lot that has to improve to get us to levels where the mortality could drop to less than 10. No one wants to see their sister die giving birth. No one wants to see their women or wives die giving birth. There are a lot of efforts that have been taken by the government, by different stakeholders, NGOs, to reduce the mortality, and it's surely on its way down.
Okay.
Yeah.
All right. And we're also joined by Sister Sylvia, who is an ICU maternity in Kawempe Referral Hospital. Good morning to you, Sister Sylvia.
Good morning, Priscilla.
First question, why do they call you sisters in the hospital? Where did it originate from?
Yeah, it originated right away from the Nightingale, who is the founder of nursing. And also people who are working in the hospitals, they were more of the religious sector, and they were the nuns. So whoever saw a nun in the hospital, they were the ones taking care of patients. So that's where the word sister originated.
All right. And how long have you actually been in this service?
Thank you, Priscilla, for that question, and even the viewers. I've been in service for over 20 years.
Okay.
Serving in the maternity sector.
All right. And in your 20 years of experience, what have been the continuous challenges that have been facing maternal health, especially for women, and nutrition?
Yeah, there are quite a number, but we realize our women lacked information about what to do when they become pregnant, or even before they become pregnant. Also, another challenge is how to accessibility to the health facility. Who links me to the hospital? How do I reach hospital? You see, they have that fear. When I reach there, what will happen? Fear of the unknown. So you get majority of our women staying at home, asking themselves questions. What will happen if I go there? Do I need to go early? What age do I go? Do I consider that now I'm pregnant, I visit
especially
the health
for first-time mothers?
Yes,
this information is always scarce.
Yes.
They will tell you about the delivery day and the experience and the pains, but no one tells you as much detail of the process of that you have to go through.
Yeah.
Okay. All right. We do have Dr. Simon. I want to engage with you, and I want to find out from you. You do come from across many situations as far as this maternal health situation is concerned in the country, and in that way, the many situations that you have come across, what have you been able to do to avert these situations, are there simple antenatal care guidelines that if they had been applied, we wouldn't be in these high numbers that we see today for the mortality rate?
Yeah, thank you very much, Priscilla, for that question. What have we done? As health professionals at different levels, there's quite a lot we have done. At the level of specialists, we are teaching. We are teaching other colleagues. We are passing on the skills. We are doing drills with the different people of different cadres, teaching them how to manage the things that commonly cause death, like something called postpartum hemorrhage, like bleeding after death. So we are always encouraged that every time you're working with anyone junior to you, make sure you teach them something new. Every contact, when you get students, make them, they may never be like you immediately, but leave them better than you found them. Then we actually participate in antenatal care. We run the clinics. When you go to hospitals, you'll find them classified as high risk and low risk. So the high risk are like mothers who have had cesarean sections before. High risk are maybe like teenagers at the lower ages. We know that they're going to give birth. Most likely their pelvis may not have grown to where they should be. You anticipate problems. Or people with diseases, other diseases like hypertension, diabetes. Those clinics are run by the doctors to make sure we pick out people who are more at risk and encourage them to do their 8 or more visits of antenatal, ask them to, and as well when they come actually for these visits, we pick out other things that they didn't know. That's why it's actually very important that they come. Like someone may come knowing, me, I'm pregnant, I need to go for antenatal. Probably when they come, you do a series of tests, you pick something else. You pick HIV, you pick syphilis, you pick rubella, something that could probably have killed their babies. And then when it's early, there's quite a lot we can do. Or some actually come to the hospital, their main complaint is, you know what, my baby didn't move today, but it's okay. You do an ultrasound scan, you find probably the baby's water is low. At a given age, you may say, let's deliver now, take the baby to ICU or NICU, and the baby does better. So there are a lot of efforts across all cadres. The nurses, they actually do the initial screening because they interact more with these patients, and then they identify. They say, oh, this patient probably needs to go here. They attach them to the referred specialties, and through that networking and teamwork, we are progressively getting to where we need to be. We are definitely challenged by numbers and some facilities are quite expensive. For whoever doesn't want to access a public facility, public facilities are overwhelmed by numbers.
Okay, I will later ask about the corruption in the public facilities. But from your submission, we get to see that now we tend to have a closer relationship with the ICU because of what you have stated. And Sister Slivia, you being in the ICU, how important is preparation for pregnancy and more so delivery from your experience of 20 years at Peripheral National Hospital?
Okay, thank you, Priscilla. Maybe to make a correction, I'm not in the ICU, I'm in the maternity. The experience I have in the public facilities is that, like I mentioned earlier on, mothers come for antenatal late. And yet, in the antenatal clinic, we need to receive these mothers as early as a mother realizes that she has conceived. She's not having her menstruation periods. We encourage them to come early, such that we book them. We call it booking. And at booking, we take a history of the previous pregnancy. We ask them about their age. How many children have they delivered? Because if you have delivered quite a number, 5 and more, you're high risk, what doctor has been talking about.
Okay.
So during the booking time, we take all histories pertaining the previous pregnancy, pertaining their family history, their lifestyle, because some of those things predispose them to being high risk. Also, when they are in the clinic with us as midwives, because we manage them as midwives, we also train our personnel in midwifery to offer antenatal care. They take their blood pressure. We take blood pressure. We take off blood for investigations, like for HB estimation. for screening for infections like HIV, hepatitis, syphilis. We even estimate for the amount of blood they have, what we call HB, such that we know the nature of mother we have in relation to being anemic. We treat them because some come with the minor ailments which are associated with the pregnancy, like vomiting in pregnancy, early pregnancy, you know, malaria. So we give them the prophylactic treatment for malaria, the Fancida. We give them albendaz tablets to kill the intestinal worms, because when they are in a pregnant mother, the baby wants food, wants a lot of blood, then the worms are also consuming the other part. She ends up being anemic and malnourished. Right. So we treat them at that level. Then once we give them health education, preparation for birth. What does a mother need to prepare from the word go for the entire period of 9 months? For example, preparation for a mama kit. This is a bag for the mother, which she prepares from that time, one item by one. Gloves, for example. A polythene paper where they deliver from. Babies' sheets, the 1.5 meters long, even the ones the baby will put on. A bed sheet for her to cover herself when she comes to the hospital. All right. A piece of soap, you know. Yeah. And then we also encourage them to come with their spouses, because we need males to be involved in this. Which begs the question, Dr. Simon, are you married? Are you a father? Okay, let me rephrase. Are you a father?
Yes, I'm a father.
Are you a father?
Of one.
And how involved were you in Mrs.'s delivery process, right from conception all the way to the delivery room?
Actually,
and what were your lessons?
I was very involved from the very beginning. I was very excited, my first child, and as well shocked. You know, you'd be like, what am I going to do? I've always been on the other side.
As a doctor, you have everything on the fingertips. Yeah. You should do this, don't.
Exactly.
But then as a...
But then this time around, you have to be on the listening side, which is usually quite challenging
for
the doctor. And but I came to learn to listen to other people. I came to learn that probably I don't have to give instructions if they have given any other instruction and I think I should do otherwise, I should call them, not rather change them from within the house. Okay. So that was a difficult position. Yes. But about involvement, I was quite involved actually up to the end, that she didn't deliver from around and I was prohibited from going due to certain reasons. But even in the decision for C-section, I was called, and then of course when people got to know that I was a doctor, they had to ask a lot of questions. Do you think we should do this? But then I was like, I'm on the other side. Yeah. If you guys think you should deliver,
then do so.
I'm waiting.
All right, so Dr. Simon Tomsange and Sister Sylvia also are here to address the maternal and child health care and also nutrition communication campaign that is ongoing right now. Tell us more about this campaign and what is it addressing in particular? I'll start with you, Sister Sylvia.
Okay, thank you, Priscilla, and our dear viewers. This campaign is all about making our communities sensitized about maternal and child health, to attend antenatal clinic early enough, such that you get a lot of information from us, like I've already mentioned. It helps them to change their behavior, because many are out there with a lot of questions in them, but when they come to antenatal clinic, we change their behavior. If someone didn't know that she's to prepare for birth, by the time she goes home, because of the health education the midwife has given, she will change behavior. And also, we get down to them to find out why they fear to come, because a survey was carried out in Kampala in 2021 to find out why mothers come so late. They expressed their fears. One of them was the health workers are so tough. they are rude, they intimidate us. So we rather stay with our judges who can care for us, who will not harass, who can support us. So we want this campaign to somehow change behavior, to bridge that gap between the mother, the spouses, and the health care facility.
Okay, all right. And what platforms, Doctor, are you using for this behavior change communication campaign?
Yeah, platforms to be we are utilizing. We are being like real and on ground, and we're using the community, starting with what everyone has, social media, their social media information going around that people can access on phones. We're using radio adverts. We're using TV stations. We're using posters. We are basically even these local radios that people call Bizindalo in their local areas. We pass on information. Religious meetings, we send representatives in those meetings to pass on information. So whatever chance we get to meet potential mothers or mothers, we utilize it to pass on information, this particular information. Okay, all right. Yeah. Dr. Sylvia, I do understand this communication campaign is not just about the maternal health care and nutrition. I do believe there are other elements that are also attached to and are complementary to aftermath of the birth or postnatal. What are those? When a mother delivers her baby, the midwife and the entire team is happy, including the family and the community. Now we are like, this baby who is born, how are we going to feed? Because malnutrition is also one of the causes of death amongst the women and even the children. So we encourage the mother, we teach them messages about breastfeeding and why we breastfeed. Because breast milk is the food that a baby who is just born needs. Does not need mushroom soup, does not need bushera, does not need anything. So we health educate them about early initiation, and we do it in the maternity immediately after delivery. Within 1 hour, we attach this baby to the breast. For whatever reason, we want the baby to suckle that colostrum, that first milk, which the breast has been preparing for the entire pregnancy. It contains all the nutrients that the baby needs. It contains the oils, the antibodies which will help this baby to be protected against infections for the first 6 months. And we tell our mothers to exclusively give breast milk without giving any other thing, formula, milk, no. Such that our baby grows very healthy. And then immunization. This baby needs to be immunized, and we teach them and encourage them to keep bringing their babies to the young child clinic for immunization, such that by the first birthday celebration, this baby have completed all their schedules for immunization. And also we monitor their growth. It's not only about giving the vaccines, the polio, the whatnot, as our viewers. You have to monitor the We have to monitor is this child growing well according to the cutoff points. All right. Yes, Dr. Simon, how else can we get affiliated with this campaign? Where do we get this information from? As we close. Yeah, you can get this information on the different websites. You can as well get to the MOH pages. You can the Ministry of Health? Yeah, Ministry of Health. You can easily access this information. All right. You can get to UFHI website as well. You get all this information, and you can as well reach out to the public health facilities, the different hospitals near you, health centers. You can always be linked. All I can say that when you really need information, you cannot fail to find it. Okay. Yeah. All right. That is Dr. Simon Tomsange and Sister Sylvia, who are here with us to talk about maternal health and nutrition, and as they have shared about the maternal and child health as well as nutrition communication campaign that has been started by the Ministry of Health to ensure that we get to drop down these percentage numbers of maternal mortality rate, as Dr. Simon has committed, to even below 10% in the near future. We wish you all the best, and we trust that this campaign is definitely going to improve livelihood and motherhood in the country of Uganda. Now, speaking of the country of Uganda,